was a question for Nader. How do you solve the problem when you are dealing with a low-grade glioma using the fluorescence guided technique you just showed, and you find function and tumor?
Right. So, function takes priority. Simple as that. I think what we were surprised was that in areas where you're beyond the radiographic margins, beyond the flare, according to the navigation anyways, it was variable how much tumor cell burden you saw in those dimensions. And so I think, Hugh made a comment earlier that if he gets to a normal area, there's no point in going another couple centimeters and removing normal tumor. But we don't know exactly what the microscopic infiltration is of quote-unquote normal brain, or removing normal brain. So I think the utility of the approach is for areas that are non-functional, where maybe you stop at 5 millimeters, or maybe you go 2 centimeters. Yes.
I loved your studies on the phase 0 studies, of course. So my question is, how do you do the selection for your patients if you don't know anything about his genetic makeup? Because there are so many drugs that you could test, and I think one of the biggest challenges that we have, that actually no single agent targeted drug has ever done anything, at least in glioblastoma. In low-grade glioma, we even don't know we know much less.
The question is, how do you select patients? And then it was a comment that monotherapies don't work, which I totally agree. The purpose of these studies are to identify the right agents to do combinatorial studies on. I think that's where we all want to go with these kinds of therapies. So to answer the first question, the drugs that we identify are typically first-in-class agents where patients haven't really seen them, because I think that's the most exciting and undefined territory that we're all obligated to explore. So we're not, for example, interested in a 4th-generation VEGF inhibitor. We're interested in a first-in-class CDK4/6 inhibitor. Selecting patients has to do with their genetic background. These are all recurrent patients, so we have archived tissue. So for example, we'll have some idea of perhaps what their genetic background is. However, the patients don't go on the drug therapeutically unless we have definitive evidence that they have the right makeup to be a responder, and we have evidence that they actually will respond. So for example, we have a CDK4/6 inhibitor that requires patients to have an intact retinoblastoma pathway. So every patient that's considered for the trial gets array CGH on their archived drug, on their archived tissue, so that we not only see the retinoblastoma pathway with immunohistochemistry, but we see, for example, CDKN2A deletion, which we know is a predictor of response to this kind of mechanism in retinoblastoma intact tumors. So we do our best within reason to enrich for patients that should have biologically compatible disease. But ultimately, we're under no illusions that the monotherapy is really just a step to get to a combinatorial trial that makes sense. Because as you can see, and I'm sure as you know, we've tried many combinatorial trials in the past, but if you don't know that the drugs are necessarily getting there and modulating what they're supposed to modulate, then you're really just kind of a little bit in the dark. So we'd like to proceed with combinatorial trials where there's already evidence that the drugs should work in those patients.
Questions?
We're all tired.
Yeah. Probably yes.
Our idea is to put everybody here, and we'll take the photo from the upstairs, okay? And then we will move to the museum by tram, because it's drizzling, like raining, okay?